Good morning, everybody. Welcome to Pediatric Grand Rounds. The voice you hear is Suzanne Mazer. I'm Director of Continuing Medical Education here at Seattle Children's. And now I'll introduce our wonderful speaker, Dr. Danielle Wendell, who comes to us after an undergraduate degree in biology and American Sign Language, med school, and then pediatric residency, which was at Children's Hospital Pittsburgh, and then Pediatric Gastroenterology Fellowship at Children's Hospital of Philadelphia. Now she's here with us as an assistant professor in pediatrics at University of Washington, the director of Pediatric Gastroenterology Fellowship here in the Department of Gastroenterology at Seattle Children's Hospital. Welcome, Dr. Wendell.
Thank you so much, Susan, and thank you everybody for joining me again here. So today I'm going to be giving an overview of intestinal failure and then also touching on advances that we've had in management and treatment of intestinal failure. So my one disclosure is that I've participated in an advisory board with Takeda. And after this presentation, I hope that you'll be able to understand the differing etiologies and complexities that are associated with intestinal failure, hopefully be able to value of the multidisciplinary team approach to care for patients with intestinal failure, and evaluate some new treatments that we're using to promote adaptation for our patients. One of the challenges in intestinal failure, and especially in research within this field, is that there isn't actually an agreed upon definition of exactly what intestinal failure is. In general, the ability of the gut to absorb and digest protein, energy, fluids, electrolytes, enough so that kids can develop and grow appropriately. This results in the need for long-term parenteral nutrition or hydration, and that's actually one of the sticking points that we have that people don't agree on exactly what is long-term parenteral nutrition. If you ask various different centers and different people, you're going to get lots of different answers for this. Intestinal failure has really blossomed as a new diagnosis, and the new intestinal rehabilitation is a fairly new field with an increasing incidence and prevalence in your patients. This mostly has happened because of advances in neonatal care. The diagnosis of intestinal failure was previously actually unsurvivable until about the 1960s when parenteral nutrition was developed. And then over the years, survival somewhat increased, but that accelerated really in the early 2000s with the development of intestinal rehabilitation centers and the multidisciplinary approach found therein. There are many different etiologies of intestinal failure. It's really an umbrella term that the most common cause is short bowel syndrome. Most of the kids that have short bowel syndrome started out life in the NICU. They have both congenital and acquired causes for this. So one of those are necrotizing enterocolitis, gastroschisis, intestinal atresias, midgut volvulus. The second major group of patients that we follow are those with dysmotility syndromes, the most common of which is chronic intestinal pseudoobstruction. This is something that requires manometry or motility testing in order to diagnose. And typically these patients start out life with their full complement of gut available, but that over time they often actually develop into short bowel syndrome patients after repeated surgeries and resections. The last group of patients that we typically follow are the congenital enteropathies. These are very rare diagnoses, the most common of which are tufting enteropathy and microvillus inclusion disease. These are diagnoses that you can see, especially on biopsies under electron microscopy. So there's structural issues with the intestine that prevent adequate absorption. There are also multiple different genetic etiologies that end up causing things with problems with transporters, enteroendocrine issues, as well as others. As you can see, there are so many different etiologies for intestinal failure, and they're very different. And so this is also another reason that it's actually difficult to study this population because it's such a heterogeneous group. And so in the past, there's been a large consortium that was previously put together, the Pediatric Intestinal Failure Consortium, which is unfortunately no longer active, but there are multiple other groups now that are trying to pull together data from various sources so that we can pool our data and learn some more about these kids. Very little has actually been studied. These next couple of slides are really to show you the complexity of this condition. This is a great picture from a review article from New England Journal, Chris Duggan-Gill, as a review of intestinal failure. I really like it because it illustrates the many, many different aspects of intestinal failure and the complexities. We really see issues from oral aversion and reflux to dysmotility, liver disease, gallstones. We see a lot of chronic kidney disease, especially in our older population. A lot of issues with dysbiosis and small intestinal bacterial overgrowth. And now something that we're seeing more and more is GI bleeding and inflammation, as well as strictures and dilated bowel. This is probably because we've actually helped these patients survive longer, and now we're seeing more of the late-term kind of complications that weren't really seen before. We actually are a referral center for the Pacific Northwest and beyond, and this is probably the most common thing that we get patients referred to us for, are some of our old patients are now having some of these complications. So one of the issues is that our kids have really a decreased transit time. This is really, this rapid transit is multifactorial, secondary to acid, bile acid, precipitation, and the diarrhea, the actual loss of surface area from resection, osmotic diarrhea from their enteral intake, the physical loss of the ileal brake. So most of our kids have, or many of our kids have lost their ileocecal valve and that physical barrier that slows things down, as well as a loss of the hormonal brake, as the GI tract is actually a very large endocrine organ and produces many different enteroendocrine hormones. The end result of all of this is really malabsorption of just about everything. And I'll get into some more of this in the rest of the talk. So as I mentioned before, multidisciplinary intestinal rehabilitation teams really took off starting in the early 2000s, late 1990s, early 2000s, and have really been quite revolutionary in care for this patient population. The goal of our intestinal rehabilitation team and these teams in general is to use a combination of medical and surgical interventions so that we can maximize adaptation. And I'll focus on that a little bit later in the talk. And our overall goal is to achieve enteral autonomy. And we do this by really focusing on minimizing complications of intestinal failure while carefully monitoring TPN. And more recently, we've been focusing more and more on the quality of life of both patients, parents, and the family unit. Studies have shown that these multidisciplinary teams have really improved survival. They've decreased the mortality specifically from liver disease, decreased the need for intestinal transplantation, significantly decreased CLABSI or central line associated bloodstream infection rates, and decreased the time required to enteral autonomy. These are the main players in our intestinal rehabilitation program, although this is not everyone that is a part of the group. Dr. Simon Horseland and I are the medical leads, and Dr. Patrick Javid is our surgical program. We have nurse coordinators, dietitians, a PA, social work, and an MA that helps to coordinate our program. The social work position doesn't have a picture right now because we're actually in search of a new social worker. This is a really imperative position within our group because, as you can imagine, these patients and families have a lot of psychosocial stressors, And so this is something that has that we actually published an abstract on earlier this year at an international meeting about the importance of social work within our group. So as you can see, this is a very complex condition, and our patients really utilize a lot of healthcare services and very often to this. Different groups have looked at what the cost of caring for patients with intestinal failure are, and this top study was done in Michigan. This is a little bit old now, it's from 2005. This was looking actually at the cost of care for patients with short bowel syndrome over the first 5 years of life. So they looked at billable charges and utilization of healthcare services. They found that in the first year of life, that's where they could account for most of the costs of taking care of these kids. Over time, the hospital costs decrease, but the home care costs increase. The mean cost of caring for a child with short bowel syndrome in the first 5 years of life in this study was $1.6 million, and there was a strong correlation with higher charges and having less than 10% of predicted intestinal length. Now, I've put up this second study, which is somewhat difficult to compare to the first study because it actually is out of the Netherlands, a little bit more recently, 2014. But because of the differences in the healthcare systems, the costs are not really comparable. The reason I included it is because they were actually looking at if there was a cost benefit to having intestinal failure children followed in an intestinal rehabilitation center, and they did, in fact, find a cost benefit. This is actually a model that they were predicting costs over 40 years of taking care of a patient, and they were looking at actual costs rather than billable charges. They found that with intestinal rehabilitation that it cost about $1.1 million versus $1.6 million without rehabilitation. So those are very different numbers from the Michigan study. What none of these studies that look at costs factor in are the indirect costs, which are very significant, especially for families. Many times there are parents that end up either quitting their job or working much less or in a different position than they normally would in order to help take care of their child. So getting back to something I touched on earlier, quality of life, this is something that our group in particular is very interested in. And in fact, Dr. Javid has been the leader of a longitudinal study that we participated in, looking at the quality of life of both our patients and their parents, and more recently looking at the family quality of life. We've we've used the PEDS-QL survey and have looked at over 120 children over 9 years. What we've seen, some of these things are not really surprising in thinking about all the things that go into taking care of these kids, but we've seen adverse effects on the activities of daily living. The parental quality of life has been found to be much less than the child quality of life, and some of this is thought to be because many of these children have had this condition their entire life, and so they don't really know any difference, whereas the parents, this is something that has happened later in life to them. The family quality of life data we're about to publish, and we found that the families that have children with intestinal failure had a comparable quality of life to families who have children with chronic illnesses, decreased quality of life compared to families that have healthy children. And our families scored poorly in the communication and worry domains of the survey, but interestingly, they actually scored quite well in the family relationship domain. Our hypothesis for this is that if parents and families, if they can make it through those first very difficult years intact, that it may actually bring them closer together as a family. We also saw that family quality of life improved over time, so that families with older children had an improved quality of life compared to younger children. These children often also are either on less TPN or off of TPN by this time. So I'm going to switch gears somewhat and focus on the goal of intestinal rehabilitation, which is really intestinal adaptation. So this is a process by which there are structural and functional changes that happen to the intestine after resection. It happens in the ileum and the jejunum and is actually improved when the colon is present. This is thought likely due to the trophic factors and short-chain fatty acids that are produced by the colon. The process helps to improve nutrient and fluid absorption, and we see muscular hypertrophy, mucosal hyperplasia, angiogenesis, dilation and elongation of the small bowel, and increased villus height with increased crypt depth as well. The process actually starts to happen immediately after resection, although it's greatest in the first few years after resection. There's probably some degree of adaptation that happens after that. It's just not as great as those first few years. We know that the thing that is necessary for adaptation to happen is enteral nutrition. And we know also that even trophic feeds are enough to help to stimulate this process. The studies have also shown that the more complex the nutrients are, the more that they assist with this process of adaptation. What we've seen when patients do not have enteral nutrition, we've seen atrophy of the intestine, of the villi, there's inflammation and colitis that occur, and there's increased liver disease that happens without any enteral nutrition. This process is under hormonal control, and there are lots of different hormones that are produced by the GI tract, including gastrin, ghrelin, peptide YY, glucagon like peptide 1 and 2. And all of these hormones help to increase the transit time, so have the intestinal mucosa exposed to the nutrition for longer. They stimulate appetite and they increase cellular proliferation. So this is really the holy grail of intestinal rehabilitation and what we aim for our intestinal failure patients. So there's been a lot of work that's gone into predicting just how long patients will take to come off of TPN and who will be able to come off of TPN. There isn't an answer to this, partly because of the heterogeneous nature of the group. And so the one thing, though, that has really risen to the top in all of these studies is that the remaining small bowel length is the greatest predictor of coming off of TPN. This table that I've included here is from a study out of Boston where they were trying to predict what would predict PN weaning, and they were able to actually stratify their patients by bowel length at about 50 centimeters. So those that had a residual small bowel length of less than 50 centimeters ended up staying on TPN for a significant amount of time, more so than those that had more than 50 centimeters of small bowel. This is definitely not something that's a hard and fast rule, but I like to think about this when I talk to new parents, because even those with more than 50 centimeters of small bowel, the first 2 years of life are a very difficult time to have TPN in a central line. So even though they might be able to come off of TPN a little bit faster than those with less than 50 centimeters of small bowel, it is still going to be a long haul and a lot of work. So the other predictors that have been shown to help predict weaning of PN are fewer infections, and specifically central line infections. Earlier gestational age, which may sound counterintuitive, but I'll talk about that next in the next slide. And having the entirety of your care within one institution. This goes back to the idea of the multidisciplinary intestinal rehabilitation center. We often get kids after they've had a lot of complications, and we have done a lot of outreach work to try to get patients earlier so that we can help their primary GI doctors or surgeons to prevent these complications. The negative predictors that have come out of these studies include the diagnosis of gastroschisis and bowel lengthening procedures. So gastroschisis is a very difficult diagnosis because it also is accompanied by dysmotility, intestinal dilation. These issues tend to worsen feed intolerance, make intestinal bacterial overgrowth worse, and just mean that most of these kids end up requiring TPN for a longer amount of time. The same is true for bowel lengthening procedures in that most kids that receive a bowel lengthening procedure do so because they have dilated small bowel that is not functioning very well. And so then we're taking a dilated, not very functional bowel and making it into a less dilated, maybe functioning slightly better bowel. So it's more of the fact that the patients that need these things have more significant disease. So as I mentioned, premature infants actually have a greater likelihood of coming off of TPN, and part of that is because of the great potential for growth of the small bowel as children grow up, and especially in the neonatal period. This is actually one of the reasons, or one of the distinguishing factors between pediatric and adult intestinal failure. In pediatrics, if part of the intestine is removed, there's still significant amount of growth that happens, which we take advantage of. In adults, if any of us lost a significant portion of our intestine, there isn't really any potential for growth of the remaining bowel. So the mainstay of treatment and management in our patients really focuses on nutrition because of the importance of nutrition in the adaptation. We see many different multiple nutrient deficiencies in our patients, the most common of which is iron deficiency. This happens partly because of malabsorption, but also because iron is not provided in parenteral nutrition. And so our patients that are on significant amounts of parenteral nutrition require IV iron infusions. We see significant fat-soluble vitamin deficiencies because our patients often have significant fat malabsorption. You'll see our patients on often very large doses of fat-soluble vitamins, and this is because they just don't absorb much of any of it. We see essential fatty acid deficiency. This can happen not as much when they're on IV lipid therapy anymore, but we do see it once they're off of IV lipids. We see micronutrient deficiencies. Most of these happen while on TPN, but some of them while off. Vitamin B12 deficiency is very common, especially because you need your terminal ileum in order to absorb this, and many of our children have lost this. Iodine deficiency, because iodine is another nutrient that's not provided in TPN. And so any of our patients that are on more than 75% of TPN, we monitor for this deficiency. And sodium, there's significant sodium and bicarbonate losses, especially in our patients that do have ostomies, especially those that have high jejunostomies. We never restrict the amount of sodium that our patients take in enterally because of all of these losses. It's interesting because we think of deficiencies happening in patients on TPN, but we actually often see worsening deficiencies in TPN because their intestine needs to try to take over the job of the parenteral nutrition. So enteral nutrition, as I've said, is really the mainstay of treatment. For infants, we prefer maternal breast milk because maternal breast milk has growth factors like ghrelin and leptin and IGF-1 and helps to induce healthy colonic flora. It boosts the immune system, and it has a lower osmolality, which our patients tend to tolerate better. When maternal breast milk is not available, which is a common issue, we do usually actually use standard infant formulas. Historically, in intestinal failure, the elemental formulas were used with the thought that it would be easier to tolerate them and absorb them, but that hasn't really been looked at rigorously in any research. And we've actually seen good success with standard infant formulas. And part of our thought behind this is that the complex nutrients help to assist in adaptation. We also know, just in general, that exposure to more allergenic foods tends to help pediatric patients in general early on. And so with that thought in mind, being exposed to these more complex nutrients may help them later on as well. We tend to use dilute formulas because our patients tend to tolerate more volume than caloric density. So you'll see our patients on quite dilute formula. We've also more recently been using more of the commercially available blenderized feeds, and these have been really quite successful. We noticed that our patients tend to do better with oral feeding than tube feeding. There seems to be some sort of feeling that many of our patients can't tolerate more formula than a certain amount, but they can typically tolerate more enteral intake. So when we looked at our G-tube usage in our group, we actually noticed that we were taking out a lot of our G-tubes quite early on in our patients. And so because of that, we've really been trying to be very thoughtful about who gets a G-tube in the first place, because we want to focus on oral feeding to try to minimize oral aversion. And so we will have our patients on very small oral feeds, as small as a few mLs every 3 hours for a long time while they develop those oral skills. And the reason that we can do this is because we have become quite good at long-term TPN management and minimizing the effects of that. Most of our children have significant hyperphagia. We hear the families telling us that these children are eating way more than anyone else in the household, that they're constantly wanting to eat. And part of this is just the malabsorption, that they have to take in enormous amounts of calories in order to actually absorb some of them. Some places have suggested that infants and toddlers need even more than 200 or more kcals per kilo per day in order to be enterally autonomous. The only restrictions that we really make on their enteral intake are on sweet foods. Now, we really try to crack down on natural, artificial fruits, juices, all of these things, mostly because they provide an osmotic load, can contribute to diarrhea. They are a great source of nutrition for the bacteria in your gut, and so they promote small intestinal bacterial overgrowth. And part of what we're doing, especially in the young childhood era, is that we're trying to educate their palates so that they don't actually want to eat those sweet foods. Most of our kids actually avoid those, and we have some interesting eating habits of our kids where they really enjoy salty, spicy, very flavorful foods and really avoid sweets. There have been multiple advances in parenteral nutrition. The most recent have involved the IV lipid solutions. Previously, we only had intralipid available, which is a soy-based lipid, and this was the only IV lipid that was approved for pediatric use. I'll get in the next slide into the effects on the liver of the soy-based lipids, but we more recently have had the approval of Omegaven, which is an omega-3 fatty acid fish oil lipid emulsion, and this has been approved for the use in intestinal failure-associated liver disease to help with cholestatic liver disease. We more recently have had approval in adults and used off-label in pediatrics as SMOF lipids. So this stands for soy, MCT, olive oil, and fish oil. This is a mixed lipid emulsion, and so it's a better distribution of the fatty acids that we're providing to patients. So I mentioned intestinal failure-associated liver disease a few times so far, and this used to be thought of as PN or parenteral nutrition-associated liver disease, but it's been recognized that there are actually many different factors specific to intestinal failure that contribute to this liver disease. Some of them with the lipids that I mentioned previously. So the soy-based lipids have high amounts of phytosterols and omega-6 fatty acids, which are pro-inflammatory. The TPN, the dextrose in the TPN may have some contribution to the liver disease as well, and this was more of an issue when we were using soy-based lipids because we were minimizing the lipids and really driving up the glucose infusion rates for the calories. The other issues with intestinal failure that contribute to liver disease are prematurity, the multiple repeated infections, the lack of enteral intake, and the contributing factor of small intestinal bacterial overgrowth, which leads to intestinal inflammation and decreased barrier function, which can contribute to liver disease as well. It is a cholestatic liver disease and is somewhat thought of as from a previous era of intestinal failure management. It used to be very common, and most of our kids on long-term TPN ended up developing this before these modifications in TPN. That's not to say that we don't see this anymore, though, especially now we're starting to see it in some of our older kids that had significant liver disease as an infant, or were taken care of at a center that wasn't familiar with how to manage the TPN, and so ended up having liver disease as a younger child. And so now we're seeing older kids that are having liver failure and progressive liver disease from intestinal failure associated liver disease. We're hoping that now with our newer patients that we are starting with, that we can help prevent much of this later on. In terms of prevention and treatment, I've mentioned briefly that while we were using soy-based lipids, we did lipid minimization. So we would try to not give more than 1 gram per kilo per day of soy-based lipids. This meant that we needed to give more calories from the other various portions of the TPN. Omega-3 fatty acids, as previously mentioned with Omegaven, this has really been something fairly revolutionary in terms of stopping the progression of cholestatic liver disease. But these studies have not shown that it reverses the damage that has already happened to the liver. So that's why patients that have been on it may still progress to liver disease or more severe liver disease later on. The mixed lipid emulsions have been shown to help prevent failure-associated liver disease, but it's not clear that they can help treat it once a patient becomes cholestatic. So we really use Omegaven more as a medication now to help treat cholestatic liver disease, and then once that is resolved, we try to get them back on the more appropriate mixed lipid emulsions. Just having enteral feeding helps to prevent liver disease and prevention of CLABSIs. The intestinal rehabilitation, just as a whole, helps to bring focus on all of these different issues and has really helped to decrease the occurrent intestinal failure-associated liver disease. So next, I'm going to touch base about CLABSIs. So these are central line-associated bloodstream infections and really have been historically a major source of mortality in our patient population. One study out of Pittsburgh had an estimate as high as 70% of intestinal failure patients who presented with fever actually had bacteremia. So that's why we assume that any PN-dependent intestinal failure patient that has fever has bacteremia. And so we will draw cultures, start antibiotics, and admit them for observation for 48 hours while on these broad-spectrum antibiotics. There is work being done to try to figure out who are these patients that don't have bacteremia, although the risk of missing this is so severe that none of these have really panned out in terms of being able to not follow through on keeping these kids in the hospital for a couple of days. The prevention of CLABSIs has really improved with the intestinal rehabilitation programs in that we have central line care bundles so that caregivers and family members are trained in how to take care of central lines. These bundles are also used in inpatient settings. We have multiple different antimicrobial locks. These have decreased infection rates significantly, specifically ethanol locks, which have been researched the most. The ethanol locks have been shown in some programs to decrease CLABSI rates from as high as almost 14 per 1,000 catheter days to less than 1, and in cases down as low as 0.2 per 1,000 catheter days. So this is a huge improvement in infection rates. Ethanol has been shown to have some difficulties with causing some complications with central lines. And so there are some issues with that. And more recently, there has been a shortage in which now it's not being produced in terms of ethanol locks. So we've had to think about other options. We try to avoid antibiotic locks because of the narrower spectrum of activity and the potential for resistance. And so more recently, we've been switching our patients to sodium bicarbonate locks. And hopefully in the future, we will have more options such as taurolidine, which has been used in many other countries, which has not had the same sort of potential effects on the catheters that the ethanol has, as well as sodium UBTA locks, which are known as kite locks. So we have lots of different options, and hopefully we'll have more of them available to our patients in the near future. So loss of central access is something that we deal with and is one of the biggest things that we focus on in intestinal rehabilitation. It's a major issue in pediatrics because our patients are going to need their central access for a very long time, possibly lifelong. And it's one of the indications for intestinal transplants. Loss of access happens because of catheter-related thrombosis, vascular stenosis. Our patients sometimes develop superior vena cava syndrome. It's a difficult thing to monitor, though, because while ultrasound is less invasive, it doesn't adequately visualize necessarily all of their access, but the other options include venograms and more invasive types of monitoring. Many of our patients end up on anticoagulation, and this is a topic that is another controversy within the field about whether patients should stay on prophylaxis with anticoagulation after they've had a thrombosis. Briefly, I'll touch base on the surgical management of intestinal failure. As I said, we work very closely with Dr. Javid. And in fact, we are often in the operating room with him when we're making decisions together about exactly what should be done for our patients. Some of the things that have happened over the years, we've realized that early ostomy takedown or even primary anastomosis is very beneficial and helps to advance feeds. And so this is something that we typically do. We often have to have anastomotic revisions done throughout the years. This is sometimes due to bleeding, ulceration, mechanical kind of kinking and obstruction that happens with their anastomoses. There are tapering and lengthening procedures that I've mentioned before. The step procedure is the picture in the center at the bottom, and the LILT or the Bianchi, LILT stands for longitudinal intestinal lengthening and tailoring procedure. This is not something that is really done anymore, but there are some older kids that you may run across that have had this in the past. The reason that this isn't done anymore is that it's a much more technically difficult surgery. As you can see in the image, the mesentery has to be divided. The dilated bowel is separated into two parallel segments and then stretched end to end, which stretches both the mesentery and often ends up kinking the gut that is put end to end. The step procedure down in the center, this uses the stapler to make these alternating cuts in the intestine, which results in this stepped longer bowel. Some of the issues behind this actually revolve around the fact that it is a more simple procedure, and so people feel that they should be doing this when maybe it's not the right candidate to do it. And so as you can see, when the staple gun is fired, there are multiple staple lines that are put in. Any of these staple lines could cause bleeding. And again, this is being done on not very functional gut. And so we do see redilation of the intestine after this procedure sometimes. So we think about it a lot before we actually decide to do something like this. I've already mentioned gastrostomy placement and closure. We end up requiring lots of endoscopies and enteroscopies on our patients. And many of our patients also need cholecystectomy. So one of the most exciting advances in intestinal failure management has been with teduglutide or Gattex. This is a hormone analog, so a GLP-2 analog that has a longer half-life than GLP-2. It has been shown to increase absorptive surface. Basically, it helps to promote adaptation. The reason that it promotes adaptation is that it leads to increased villi length, increased crypt depth, and this helps to increase absorption. There's also decreased gastric emptying, which sounds like it might not actually be a great thing for our patients, but it actually just helps to slow things down through the GI tract. It's a daily injection. The durability of its effect is not really known and is being studied more in adults, but what we have seen is that when our patients have come off of this medication, they do lose the effect. And it has now recently been approved in pediatric short bowel syndrome for patients over 1 year of age who are on stable TPN. It does require monitoring because it is a pro-proliferative medication, and so there's always been concern that it could promote polyp formation and other issues. In the adult studies, they have seen polyp formation, but the studies have not been going on long enough to say whether there's a significant increase associated with the medication. So there are ongoing longitudinal studies for this. We have not seen that in our pediatric patients on this medication. These histologic pictures are just showing the increase in the villi length and crypt depth associated with this medication. So we participated here at Seattle Children's in both of the two pediatric trials of teduglutide. The first was a 12-week trial. This is from the 24-week trial. We were one of the highest recruiters for the first 12-week trial. We also participated in two extension studies from these trials. So we actually have quite an experience with this medication, and it's actually one of the reasons that we get a lot of referrals now from various centers to start patients or at least evaluate them for the use of teduglutide. This 24-week study included 50 patients receiving teduglutide and 9 patients on the standard of care arm. It was looking at a primary efficacy and pharmacodynamic endpoint of a reduction of greater than or equal to 20% reduction in parenteral support volume at 24 weeks. The other endpoint was reduction in calories. These are the results of the study. And so as you can see, that primary endpoint was reached, and the patients really had a great decrease in their parenteral support. We have actually seen at least one of our patients that has been able to completely come off of TPN, have a central line removed, and now even have his G-tube removed, who has been on teduglutide for many years now. So we've seen significant improvements using this medication. Future research in intestinal failure, really this is the gateway to future research, because in the future, we're hoping to look at different dosing frequency, possibly not requiring it on a daily basis, maybe different administration routes of medication, combinations with other hormone analogs. And possibly in the more distant future, having some sort of precision medicine that's tailored to patient diagnosis and remaining anatomy. Those are quite far off in the future, but this is really promising in a start to that goal. So the last thing that I want to touch upon is intestinal transplantation. So the frequency of transplants has really decreased over the years, and this is really a fact that has happened because of intestinal rehabilitation. So because we've gotten so good at rehabilitating patients, they haven't needed to go on to intestinal transplant. The indications for transplant have been updated recently and include progressive intestinal failure-associated liver disease. This is in the face of trying lipid modifications, and so patients that have reduced synthetic function or portal hypertension as well. Loss of central access is one of the indications that's becoming more and more common, and now is defined as thrombosis of 3 out of 4 discrete upper body central veins. So those are subclavian internal jugular veins, or occlusion of a brachiocephalic vein in pediatrics. The life-threatening ICU admissions for CLABSI in pediatrics, it's been recommended that having 2 admissions to the ICU for these should be an indication for transplant. And there are other indications more rare, such as abdominal tumors, total intestinal aganglionosis, congenital secretory diarrheas, as we discussed before, or acute diffuse intestinal infarction with hepatic failure, and also a failure of a first transplant. There are really a lot of challenges to intestinal transplantation, and the outcomes of long-term TPN are just as good in many cases, if not better, than the outcomes of intestinal transplant. And so we're very picky in terms of the kids that we are transplanting. Some of the challenges include immunosuppression, because the intestine is really exposed to the outside world, much as in lung transplant, which is also quite difficult in this regard. The high requirements for immunosuppression then can lead to other challenges, such as infections and PTLD and various other issues. There's also a difficulty in allocation and choice of organs, in that many times the intestine is affected by whatever the cause of death was, and is not an appropriate organ to use. And so this leads to a lack of organs in general to choose from for intestinal failure patients. One of the other challenges is that we've gotten better at the survival of the graft in the first year of after transplant, but the long-term survival of the graft really hasn't changed over the years, and remains in some studies at 40 to 50%. So it remains something that we really need to focus on, though, because now that we've gotten so good at rehabilitating patients, we have patients that are surviving that never survived before, who will never be able to come off of TPN and will eventually need intestinal transplantation. So this is an area that remains a focus. So in conclusion, I hope you can recognize that intestinal failure is a very complex condition with really many potential complications, but that multidisciplinary intestinal rehabilitation teams are narrative to help decrease the morbidity and mortality for patients with intestinal failure, hoping to prevent complications and treat them while we're working towards enteral autonomy. Really, this has happened because we've had improvements in long-term PN management that gives us time to allow for that intestinal adaptation to happen. The future of treatment of intestinal failure really seems to be in these hormone analog therapies that are providing a new and exciting avenue to promote this adaptation, but that we need to continue to focus on intestinal transplant, because there will always be a group of children that require this life-saving intervention. And with that, I'd like to thank you, and I'd be happy to answer any questions.
And we already have a question, so I will start with that from Anita Beck. Great talk. can you talk about the intellectual/motor development and growth patterns, length, height, weight, head circumference in these children?
That's a really great question, and something that has been focused on more recently. So there are studies that show that there are decreased neurodevelopmental outcomes in our patients, and so there's been a push to make sure that referred to services early on. Whether this is more related to the intestinal failure diagnosis versus the prematurity, multiple admissions early on, that has not really been teased out. But we do know that there are issues with neurodevelopment in this patient population. In terms of growth and development in general, we do see that for most of our kids, we can achieve fairly normal growth rates with TPN. There are some kids that that's not true for, the ones that we are really trying to maximize TPN and are really struggling with that. Sometimes we're not able to achieve that. But in general, with parenteral nutrition and really being patient and giving their gut time to adapt, many of our children do achieve a fairly normal growth.
And from Glenn Tamura, I learned a lot. Can you tell us more about taurolidine? I'm not sure if I'm
Yes.
taurolidine, sorry, to prevent CLABSIs. Sorry
Yes.
about that.
So taurolidine is something, it's an antimicrobial lock. It neutralizes the bacterial exo and endotoxins and prevents bacterial adhesion to host cells. So it is not specific. So it works on all types of microbes. And it's been used for quite a while in other countries. So in Europe, Australia, Canada, they've used taurolidine for quite a while. It has more recently, it's going up to the FDA, and so we're hoping that we'll actually get it to use here. It has similar outcomes to those of ethanol, and so significant improvement in CLABSI rates, and it has not shown the same sort of side effects of ethanol in terms of effects on the catheter. So it's a really promising antimicrobial lock. But one of the things that I think is really important to say is that we really need multiple different antimicrobial locks for our patients, because one of the things I didn't bring up is that there have been national shortages on basically every component of parenteral nutrition and these locks as well. So we really need lots of different options that are good options, because I don't imagine that these shortages are actually going to completely go away, and we'll have to face different shortages in the future.
And again, thank you, Dr. Wendell, for being here, and especially for your patience with our WebEx failure at the first round. And everyone else who's listening, make sure to fill out an evaluation when you get it in your email, and contact me or Emily Rice or Kathy Cohorn for any recommendations, things we can do better for Grand Rounds 2021. Hopefully we'll see you in person one of these days in the next, I don't know, 6 to 8 months or so. So thanks, everyone. A lot of comments in the chat just saying thank you so much, Dr. Wendell. I think we can let everybody go and take back this last 5 minutes of your Thursday. And we'll see you all next week. And again, thank you so much for everyone for being here.